But welcome and thank you so much for coming to our webinar, Preventing Teen Suicide. Today, our panelists are Dr. Elizabeth Olson and Melissa Horn. They're both going to talk about, well, since September is Preventing Suicide, it's Suicide Awareness Month, we thought this would be a good topic to discuss. So if you have any questions during the talk, feel free to just put them into the chat, and I will see them and feed the questions to Elizabeth and Melissa, and they'll either answer in real time if they can, or at the end we'll have time to answer questions as well. If you like, you can also send me a private message if you prefer to be more anonymous with your questions. Otherwise, you feel free to just send them to everyone in the chat. And if you have any questions throughout the webinar, feel free to message me and I will try to help as best I can when it comes to technical difficulties or anything like that. So yeah, without further ado.
Thank you so much, Kelsey. So I put this webinar together with the idea that I wanted to try to help raise awareness, help to educate about preventing teenage suicide. I think recently it's been in the news that there's, of course, a higher risk right now with the pandemic and the kind of stress that adolescents and families are dealing with right now. There's concern that suicide could, or the potential for suicidal behaviors could go up. And so I wanted to do this webinar both to educate myself as a clinician and as a parent, but also to be able to educate parents and other clinicians about some of the risk factors, some of the evidence for risk factors that could put kids more at risk potentially for suicidal thoughts, behaviors, actions, attempts, and also to try to raise awareness about protective factors that people can hopefully try to cultivate and consider as a way of insulating kids from suicide. And then I'm going to talk just really briefly about some of the treatment modalities. We're going to go into more depth around dialectical behavior therapy because that's one of the treatments that we offer at the Collective for psychological wellness, and it's one of the ones that I'm trained in. And so, and as is Melissa Horn, who will be talking today as well. So I hope that you find some of the information and the resources that we try to speak to useful and helpful. And I'm going to start by, well, actually, Melissa, if you want to introduce yourself, then I'll go ahead and start my talk.
Sure. So I'm Melissa Horn. I am a dialectical behavior therapy, and I do groups and individuals as a facilitator. I I am a psychotherapist, and I have experience with young people and substance addictions, different things like that. And I have found for myself, DBT to be very helpful with the skills. And so that's what got me into being a DBT instructor as I became a therapist. And I'm happy to talk about some of the suicide prevention skills that DBT has. It can work with a safety plan and kind of manipulating your autonomic nervous system in the moment when you're having different urges.
Great. Thank you so much, Melissa. Okay. So I'm going to start by sharing my screen and see if I can do this. Let me see. Okay, can everybody see my screen? Is that working? Melissa and Kelsey, is that working? Can you tell me?
Yes.
Yes, yes.
Thank you. It's my first time doing this with a shared screen, so. Okay, so as I said, for my talk, the primary things that I'm going to talk about are the possible risk factors, the importance of protective factors, and the strategies for prevention, just a little bit there. So what I wanted to say is that the research is pretty, it's just not that, oops, something is coming onto my screen. Okay, here we go. The research is pretty there's just not a lot of it, unfortunately, especially on causative factors for what causes teens to be suicidal. There's kind of evidence that we can look at and correlations to certain factors that we can consider. And some factors do seem to be higher than others. So I'm going to talk a little bit about that today. But to start with, I wanted to say that suicide is currently the second leading cause of death for teenagers between the ages of 10 and 24. Suicidal ideation occurs in 12.1% of teens. 4% of teenagers actually have a plan. And suicide attempts can be, for some reason, it's ranking at 4.1%, which is even higher than a plan. So some people may just act on it really impulsively. 17.1% of high school students have considered it. 1 in 10 high schoolers attempt suicide. And for some reason, I think this is a really disturbing statistic. 10 to 14-year-old female girls, there's been a 200% increase in suicidal behaviors over the last 15 years. So something is really not working. And I wanted to try to put this together to see if we can understand better what some of the factors are that could be causing people to be more at risk for this. Teenagers. So as I said, it's the second leading cause of death for adolescents between the ages of 10 to 24, according to the CDC, and it's second to accidental death. The types of risks that I'm going to talk about today are basically in kind of two different categories. One is more fixed risks, so the kinds of things that you can't necessarily change, like age, family history, genetics would be examples of that. And the risks that are fixed are not as great to target in terms of what kinds of things intervention can, change, because these are not changeable characteristics. So the ones that we want to think about are the more malleable risks. And so I'm going to talk about both, but the malleable risks are the ones that we try to target for intervention. Those could be things like sleep disturbance, problem-solving abilities, the capacity to cope. These are all things that can change and improve and get better. And then the risks, I wanted to just put a definition up here about what a risk is. A risk is basically something that makes it more likely that a teen will possibly engage in suicidal thoughts, actions, or attempts, and something that could weaken protective factors. So protective factors, again, are these things that will help to insulate a kid, a child, a teen from this kind of behavior. I want to try to get this off my screen. Okay, here we go. Let's see, how do I get to, okay, here we go. So like I said, the research on teenage suicide is lacking, and there really isn't any causal research for suicide. So basically the way that causal research would have to occur is that you would study something that definitely changed the impact of whether or not someone was more or less suicidal or engaged in suicidal behaviors. Right now, it's based more on kind of theoretical ideas and variables and factors that are getting correlated or considered as possible evidence towards the risks. So one of the leading theories that has been studied the most in terms of suicide is interpersonal theory. And the two kind of tenets of interpersonal theory related to suicide in teenagers is 1, a desire to die, and 2, the access to lethal self-injury. And so those are two variables that have been considered. And then there were kind of 3 components that were considered also as part of interpersonal theory, or kind of posited as potential risk factors for teens. One being a lack of belonging, or you could say feelings of loneliness, feelings of being a burden, and feelings of hopelessness. So one of the biggest risk factors that people have found in studying suicide with teenagers is the capability, the access to capability to doing it. And the way that that is operationalized is that these are kids who would have less of a fear of death. So one way that I have seen it and experienced it in my practice with kids and with adults is kind of an indifference to death or a flatness around it, where they don't necessarily have a strong desire to live and they're not afraid to die. And then the second one is an increased tolerance for physical pain. So kids who have an ability to tolerate pain, aren't afraid of pain, and don't mind pain as much as maybe other kids. And it's interesting that the access to capability is the one variable that is consistent across all the other variables that were studied and across both genders. So the research has not found a connection between all three of these variables, but what they did find was when you broke it down into males and females, for males, there was a greater perceived burdensomeness, or that feeling of being a burden, paired with a higher acquired capability. So with what I was talking about before for capability, based on past suicidal attempts, that kids that have been hospitalized are going to be more likely to attempt suicide 3 months after discharge, males especially, if they have the feeling that they're a burden and if they have that capacity to not feel afraid of death and to be able to tolerate more pain. Now for females, the combination was a lower acquired capability mixed with greater loneliness, that the two together after 3 months of discharge from a hospital were more likely to attempt suicide. So I don't think that the acquired capability had to be as high as it did for males, but it was still a factor for people. An ability to be able to tolerate pain and to not be afraid of death as much, or to have an indifference towards death. Some of the other risks to consider are major depressive disorder. While not all kids who attempt suicide are depressed, in fact, in some cases, anxiety is actually a bigger factor than depression for kids with suicide. Major depressive disorder is, however, correlated with suicide. And let's see here, especially when it is comorbid with another disorder such as social anxiety. So one of the things about pairing major depressive disorder with social anxiety is that apparently in a longitudinal study, there was a higher likelihood for a later attempt in life. Impulsiveness increases the chance of both suicidal ideation and suicidal attempts. Impulsiveness, sometimes you can see it in disorders like ADHD, which definitely has a higher risk for suicide. But any kind of impulsiveness, and it's one of the things that's so hard with teenagers because their brains are more wired to be impulsive, which just inherently puts them more at risk for taking impulsive behaviors towards suicide. And then the other factor here was children who developed major depressive disorder before the age of 14 were at an increased risk for later suicide attempt. The concern is that a mental disorder will result in delayed or underdeveloped social skill competence. So basically, if kids have a significant mental health disorder, it can remove them sometimes from the social situations that they might need to be able to develop that competence or to feel like they belong, and it can put them more at risk down the line if they're struggling socially. And then feelings of worthlessness combined with anhedonia increased risk as well. So anhedonia is basically the inability to feel pleasure. So for some kids, anhedonia would be a factor because they don't necessarily feel like excited about something or looking forward to something, or they don't know how to feel as happy or as joyful when good things happen as maybe other kids do. And it was interesting because it wasn't necessarily negative affect that contributed as much to the possibility of suicide or negative outlook or negative feelings, as much as it was anhedonia, the inability to be able to experience joy or happiness. And then certainly feelings of worthlessness are a factor for suicide as well. Another factor that I think is really important to speak to and to name is that kids can be depressed and not necessarily be suicidal. But one of the things that they found in the research was that when there is a really significant change in the way that the teenager experiences their depression or their ability to function in their life, that is a real area of serious concern and something to really pay attention to. Is the teenager more depressed or less functional than they usually are? So you could have a kid who's generally depressed and they maybe aren't going to be as at risk for suicide, but if you notice that the depression takes a real turn for the worse, then that's something to really pay attention to. So you're kind of looking for what is the typical state of depression or the typical state of being as a guide for that person, and then going off and assessing for, is there a significant change that's happening here? Hopelessness is definitely a factor that is correlated with risk for suicide. And it's interesting, again, it's not so much the idea that I guess the idea of negative outlook isn't as much the factor here as having a low expectation that things will turn out well. So it's a little bit different. Again, it's similar to the anhedonia and the negative state. It's not that being pessimistic is as much the problem as it is that you don't have the feeling of hope that when something goes well, it's going to kind of portend for positive things in the future. It's a lack of positive hope or expectation for good things to happen that puts kids more at risk for suicidal behaviors and thoughts. Another thing that can be a factor here is negative self-referential thinking, which is basically the processing and retaining of information that is negative about oneself faster than positive information. And it's actually the case that our brains are wired to view things more negatively or to pay more attention to the things that are negative. And it's sometimes harder for us as humans to kind of savor or appreciate the things that are positive or that go on well. We tend to remember and focus more and kind of take in faster and more strongly, more intensely the things that are negative. And so this is a thing where if a child or a teenager is thinking really negative thoughts about the self or hearing things from the environment that are critical or negative, they're going to hang on to that more, and that can put them more at risk. Negative inferential thinking, so believing that negative events portend poorly for the future. So if something negative happens, instead of being able to think about it like, well, this thing happened and what can I do to make the best of it? Or what can I do to problem solve this? Or how can I address the situation to improve it? Instead, kids might ruminate about things in a negative way and then sort of say to themselves, well, if this happened, then that means this is going to just continue being bad for me in the future. Some of the other predictive behaviors that are talked about are underage, cigarette smoking. Aggressive behavior can sometimes be a risk factor towards suicide. Lower extroversion in males, so males that might be more quiet or introverted or tend to keep more to themselves could be more at risk. A tendency to view things negatively, as I've talked about, low self-esteem, negative ideas about oneself, And then another one, sleep problems are a big factor for that, and insomnia. And sleep problems can certainly lead to depression. So we can see how it could also potentially be a risk factor for depression. Unfortunately, one of the things that's really good about sleep problems is that those can be addressed in a lot of different ways on a behavioral standpoint or even medically if needed, so that kids can sleep better. But that's definitely an area to keep an eye on if your child or a client that you're working with has sleep issues or insomnia. That's a good thing to address. So the biggest predictor for suicidal behavior is actually previous attempts at suicide, previous suicidal behaviors or previous suicidal attempts. It's the number one risk factor that can put kids in a likely situation to try to attempt again and possibly complete suicide. And you can think about it again along the lines of the interpersonal theory of the decreased fear of death and the increased capacity for pain. Because if a teenager or a child has attempted suicide before, they've already demonstrated that they're possibly less afraid of death and that they have an increased capacity to tolerate pain. Another factor that's really significant for suicidal behavior in teenagers is high family conflict. And some of the ways that this can kind of manifest are through parents that might be highly controlling, parents that might be highly critical, emotionally unresponsive parents, parents who maybe aren't available to provide support for some reason, a lack of care, or if the child experiences a feeling of rejection from the parent. That can be another factor that could lead towards this. So when you're working with, or if you're in a situation with your child where there's high conflict, I'm going to talk a little bit about this in a bit, but the thing to really focus on is how to repair and rebuild that relationship and to make that the number one priority. Because in addition to family conflict being a risk, it's also family cohesion as a protective factor. So it's a really good area to focus on if conflict is high in the family, to work on improving that to help reduce the risk. Other factors that can really be big contributors, I think, to suicidal behavior are physical abuse of any kind, sexual abuse, and emotional abuse. And certainly, if a child or a teenager has experienced all three or some combination of any of these types of abuse, the kids are much more at risk for suicide. And particularly with sexual abuse, especially if it happened with an immediate family member, if the abuse was chronic, and if it occurred before the age of 13, it can actually put an individual at risk for suicide for a lifetime. Other kinds of things to think about are family history. One of the things that I had heard before, and I didn't actually come across it in the research I was reading for this, but I had heard this before, that one of the factors that can contribute sometimes to suicide in teenagers and young adults is if there was a grandparent or someone in the generation above the parents that committed suicide. That can actually increase the risk. And then there's, if parents have suicided, that could certainly do it as well. But I had heard in some research that it's possible that suicidal behavior may skip a generation. So that's something to keep in mind. And then peer victimization is a huge, I think, factor. And if kids are going to school where they're spending 30 hours a week with other peers, which I know we're not doing right now, but you can still get, I think, victimized online, and that can be just as detrimental, if not more so, that kids are getting exposed to maybe negative, ways that kids are talking to them about who they are, or putting them down in various ways can be very damaging to kids' self-esteem and to who they are as a person, and can really put them at risk. And it can fit along the lines of that lacking of belonging and feeling really lonely, combined with low self-esteem and worthlessness if they're getting picked on. Apparently in the research, one of the things that they found also is that bullies who both do the bullying but have also been victimized are at a higher risk than other kids for suicide. And then another factor that's really significant is exposure to a friend's death by suicide. And this can get into the realm of cluster suicides, or sometimes even in the media, if suicides are reported in the news. For some teenagers, just even hearing the word suicide, or having the thought that someone else had completed a suicide can put them much more at risk. It might increase their capacity to think that they could do it for themselves. And there can be sometimes like a contagion that can occur. And so it's really important to be careful when there is a suicide in the community, to really work on increasing resources and wrap around the kids in that community to help them get the resources that they need if they are feeling that they are suicidal, or to reduce the risk that kids will engage in that behavior if it's occurred by a friend. So to keep a close eye on that person. So now I'm going to move into talking about the protective factors that can help to prevent suicide, or at least maybe insulate kids from suicidal thinking, suicidal actions or attempts. And one of the biggest ones actually is family cohesion, which I mentioned a little bit before. So having a focus on improving the parental relationship and making safety matter the most. So along that line, there is a type or a modality of family therapy right now out there that's called attachment family therapy. And it's a modality that focuses on repairing the relationship between the teenager and the parent, and helping to reestablish if there wasn't, or if there was a secure relationship, or to create a secure relationship between the parents and the kids. And one of the things that they have found is that teenagers who report that they have parents who have similar interests to them, who they report provide emotional support to them, who they feel close with and connected with, are 3 to 5 times less likely to commit suicide. So family really matters. And if there is conflict in the family, whoops, it looks like something came on my screen. If there is conflict in the family, it's really important to address that if you can, and to take that really seriously, and to work on repairing those relationships and providing the teenager with at least one parent who they feel close with and who they feel like they can really rely on, who they're going to be more likely to come and talk to if there is a problem. That's one of the ways that you want to think about it, is that you want to try to create a relationship where the relationship matters the most. It's the number one thing, and who the kid feels safe coming to you for support and help with. Other kinds of protective factors that you can be aware of in kids and maybe try to cultivate are low levels of novelty seeking. So kids who aren't necessarily as wired as others to seek risk. So that's something just to keep in mind in terms of a risk factor, is kids who are wanting to go towards risky behaviors could be more at risk. And then kids who have lower levels of seeking novelty are going to be in a more protective, that could be more protective for them. Lower levels of negative thinking. So this can be a target area for therapy, is helping to find ways of coping with negative thinking if it is there, and to help kids develop things that they can do that help them to feel good about themselves and to help them cope when the negative thinking is there. High self-esteem is a protective factor, so certainly working on self-esteem is a target area and something that can definitely change. And one of the things that in the research that I've read has indicated is that actually working on self-compassion can be even more effective than self-esteem. So helping kids to learn to have, to basically be a friend to themselves, to have a compassionate internal voice that talks to them in a way that is kind and caring and understanding and encouraging, so that they can go towards things that would be more, positive and supportive for them. The other thing that I think is interesting here is the capacity to problem solve. And this is one of the things that we see a lot in DBT. The skills that you learn in dialectical behavior therapy are a lot focused towards problem solving. How can you see the things that are the difficulties, sometimes even anticipate the cues that could cause stress or distress for the teen, and then come up with solutions, have maybe a variety of options available to the teen to help them think through and problem solve how they can address the situation and make it better. And this, in DBT, we focus on things like improving relationships. So where are the relationship difficulties and what are ways that you could do that differently? Managing your distress better if that's a problem. When you're getting really dysregulated, here's some options that you have, some tools that are available to you to help really address that problem. Family difficulties, what are the ways that the parents could do it differently? So really having the idea that kids can solve their problems and that they have the hope or the idea that that's possible. The ability to distract from negative thoughts and actions. Another skill that's part of DBT that's very significant is distraction. So being able to come up with other things that are so alluring that you wouldn't want to focus on those negative things. So distraction is a huge skill that we try to teach. And there's lots of different ways of doing it. And sometimes the distraction has to be really, really strong because the negative thoughts or the negative actions or the pull towards doing something that could be dangerous could be so strong that the distraction has to be equal to that in strength, if not more. Another protective factor is grit. So the ability basically to persevere and get through hard things and to be able to tolerate hard things to some degree. And this is important because kids need to be able to experience frustration. They need to have that experience to be able to build a tolerance for it. They need to be able to experience their distress and cope at the same time, but be able to tolerate it and find their way through it. Another factor is social connectedness. So helping kids to have a variety of different outlets that they can feel connected and feel good and positive about themselves in those connections. So really trying to cultivate and grow the relationships that are pro-social, that are good for the kid, and that help them to feel good about themselves. And then another protective factor that was talked about is religion or religiosity. And in specific, the use of prayer is a protective factor as well. So this could be any form of prayer that works for that teen, but having some connection to something maybe that feels bigger than just oneself. And in DBT, we do talk about prayer and we do talk about mindfulness, not necessarily in a religious way, but more even, just for gratitude or having some feeling to connection of something bigger, that you're not alone, that you're a person who's interconnected with other people, even if it's not necessarily spiritual. Although in DBT, there is an encouragement to cultivate some kind of a spiritual relationship. And in my clients that are more atheistic, I do encourage them even to think about just a connection to nature can be really helpful. The main thing is to not have to feel like you're alone. So some of the strategies to consider for reducing the risk of suicide, the number one thing that has been found to make the biggest difference, the biggest strategy to employ, is reducing access to lethality. across the board, it's the number one thing that can help to reduce the risk of suicidal behavior. So what this basically means is removing or restricting any and all access to the means for suicide. This could mean, keeping any kind of toxic substances, any kind of, things that could be used for, that could be dangerous or harmful in some way to someone's body. You basically restrict those things and make it impossible for the kids to have access to that. It could be having a lockbox, a safe. It could be removing the things from the premises altogether. There's research to show that just by having a gun in the home, even if it's locked up, the risk of suicide is much higher in those homes because kids can sometimes find a way to get access to those things. So it's the number one way to prevent a completed suicide and to reduce the likelihood of an attempt. And then the other piece that goes along with reducing the lethality or the access to lethality is parental monitoring. And sometimes what parental monitoring can include is room searches, backpack searches. Even though it may feel like an invasion of privacy, it's basically putting safety above privacy, that you want to try to help to mitigate any of the potential ways that a child might have access to this. And parental monitoring is something that can help. If, however, parental monitoring doesn't feel like it's enough, and that's something that the family, I think, has to assess for, as well as the therapist, if the therapist is involved, then sometimes there is a real consideration for inpatient care. It's a big step to take, but sometimes it's a needed one. And it's a way to, mostly guarantee safety for sure. And part of what you want to do is think about that it's kind of like riding or surfing that urge, that time period when the teen might be most at risk, being able to provide them with the monitoring to prevent them from taking any action that could be deadly or dangerous. Okay. Another strategy that we encourage all therapists and families to consider is creating a safety plan. And Melissa Horn is going to talk more specifically about this, but I just thought I'd say a couple things about it. Understanding the internal and environmental cues that can lead toward a suicidal state. So basically, one of the things that we use as DBT therapists is chain analysis. And we look to try to identify what are the cues in the environment that cause distress for the kids. What are the cues that could be internal? So the way that maybe they get into a thought state or a thinking state that is causing them to feel hopeless or worthless or to have negative thoughts about themselves or their future. Those are the kinds of things that as a therapist we're assessing for and trying to understand. What are the cues that might go on in the family that could predict that? For some kids, it might be shame. For some kids, it might be just the stress of a fight. Whatever that might be, that could be a cue for that. Being able to have that in mind. And in DBT, there's a thing called coping ahead, which is where you identify what those cues are, and then you try to create a plan for how to prevent it from becoming something that could be dangerous. One of the ways of doing that is having a really, really clear, specific safety plan that the teen can keep with them at all times, and that the teen can have access to whatever those coping strategies are that are on that safety plan. And one of the things that I sometimes encounter with parents in my work is whether or not their teenager should have their phone. I'm a proponent of not taking the phone away for punishment purposes, especially when a child is dysregulated, because that might be their way of having access to calling for help if they need help, like a safety line or a suicide hotline or their therapist or a trusted friend or family member that they feel connected with who could support them. Being able to reach out, I think, is really important. Some of the coping skills that we're going to talk about today are distracting, tip skills, soothe, and we may say something about mindfulness, but those are all skills that we try to encourage kids to use. And then another piece is just reminding kids about the reasons to live, and having that available to them. Why would they live? What's important to them about their life? And then Marsha Linehan talks a lot about creating a life that's worth living. One moment, I just have to cough. Sorry, my my asthma is coming up. I apologize. Let's see here. Sometimes when I talk a long time, my vocal cords get kind of stressed. So a hope box is something that I learned about in one of the books that I've been reading. And what I've always talked about it as, and what we've done at the collective, is like a coping skills kit or a coping skills box, but I loved the idea of a hope box. So a hope box is something that a teenager can have, that they should have access to at all times. And in the hope box could be things like pictures of family members, maybe some messages from parents or friends about how this person is loved and cared for no matter what. Different kinds of skills that they might use, and their safety plan, as well as numbers and resources listed in the box for kids to be able to call on if they're feeling suicidal. So actually helping the kid to develop the hope box and having access to it can be really important. Excuse me. The virtual hope box is another thing, and I put a link here towards the virtual hope box. That's something that is online, that kids can build a hope box online in addition to having a physical one. But just in case they are somewhere where maybe they're experiencing suicidal ideation or an urge to try to kill themselves, but they don't have the hope box nearby, having a virtual one on their phone could be helpful to them. Let's see. There's also a safety plan resource. So there's a best practice safety plan, and I put a link to that site so that if you don't have access to one, you can take a look at this one and potentially use that one. And they can be modified so that they fit for the individual teen and family. And then local resources in Boulder. I recently learned about Rise Against Suicide and Coley's Closet. So those are two local resources that are working to prevent teenage suicide and provide resources and support to kids who are depressed or suicidal. And then there's a Colorado crisis line as well that's available 24/7. And there's actually a Colorado Crisis Center, but I don't know. I think they are still accepting clients, but it may be a little bit different. So it might be good to call first before going, given that we're in the time of COVID. And then certainly there's always going to the emergency room. And then on a national level, there's the National Suicide Prevention Lifeline, and I've included that number here. And it's really important for kids to have something like this printed out for them so that they, in the moment, don't have to think too hard about looking for a number or something. You want them to have easy access to the resources and the things that could help them if they're really in a hard spot at that moment. So thank you for taking the time to listen to my talk on suicide prevention for teenagers. I hope that it's been helpful. And if you have questions, I'm happy to try to answer them. And Melissa's gonna talk a little bit now about DBT.
So I also have a screen to share. Let me go ahead and do that real quick. And share. Oh, right. That's the end. So, um, we're having a teen suicide discussion. I find that I'm actually going in to teach some of these skills that I'm bringing here today in my teen group this afternoon. It's all very timely. Um, I think, as Elizabeth was discussing before, that it's very important to have a safety plan, especially I think it could be good to start assessing safety, especially if there's any self-harm, maybe before you get to the point where there's suicidal ideation, but I'm still working with safety plans and when they feel most effective. Um, some good questions for the safety plan. These come right off of a DBT-centered one. My reasons for managing crisis effectively and or staying safe. So these are, again, some of the things that you would put in the hope box. The reasons that you're tethered to the world. The reasons that your teen is tethered to the world. Um, your pets, your home pets, your family members, your siblings, goals, values, people, the whys that motivate you to use this plan. So that's why it's a great idea to keep this plan in your hope box. I love that idea. It's also a great idea to have several copies of it around, more than one copy. Um, so another thing to put on there would of course be strengths and resources, and really thinking about those and getting young people talking about their strengths and resources. It's pretty easy to overlook those things when you're feeling depressed. And you might notice that their language is more negative, and that often means their thinking is more negative as well. So it's really important to start focusing on what is working, what they do have in certain situations. Comparisons can be slippery, but that is actually a part of this, is looking at how things could be worse, essentially. Um, Another good thing to look at are warning signs. This actually is 1, 2, 3, 4, about 5 questions in all, but I really reduced it so we could talk about it briefly. Warning signs can be feelings, thoughts, behaviors, and sensations. You want to be really specific. A lot of times we're talking about somatic warning signs. So um, the way it feels in your body as soon as something happens or as soon as that thing is said. These can be what people call triggers. These can be what I like to call cues. They can be a sound. It can be a smell. So you can be triggered through any of your 5 senses as well as feelings, thoughts, behaviors. Um, so just be aware that depending on what this teen has been through, their level of trauma, um, this warning sign part may be longer. The more trauma that a person has in their system, there could be more things setting them off. These are some more kind of basic questions that are typically included in a safety plan, but that you really want to make sure are on there. Key triggers, we talked a little bit about that. It may be kind of a different language you have around key triggers. Skills that are actually useful, so things that are already working, and then you can build on those skills. DBT is a very helpful way. List personal support systems with contact info and professional support systems. You definitely want to make sure that those things are there. Suicide prevention hotlines. The younger generation is much more into texting, and they do have texting hotlines now, 24 hours. So they can be texting with people. And if that feels a little bit better in the moment, whatever is helpful. So look into, local ones are always better, but there are national support lines as well. And these are things that you build within the safety plan. You go ahead and take the time to look these things up while you're doing it. We want to go ahead and talk about boundaries around treatment interfering behaviors. So this is very important. How much is too much before we need to discuss a higher level of care or consequences for actions? So if X happens, then you may need a higher level of care. We may need to try something different. You may need to try a partial hospitalization program. You may need to be hospitalized depending on the severity of what's going on. Some treatment interfering behaviors are more drastic than others, and we're going to talk about urge surfing in just a second, but trying to decide where the line is essentially, and making an agreement around that, that everybody is on board with, so that they know when this thing happens, this is what's going to happen. And it's very good for the nervous system to understand that. This last part is an example of a commitment, something that you could put at the end of your plan, something that you'd want to kind of put in your own words. But essentially, you're kind of signing off on this agreement. And this one is very simple. It just states, I commit to practicing my plan proactively during times of crisis. I further commit to be safe and call 911 or go to the hospital before acting on suicidal urges. And again, all of that information is right here in front of them, so they don't have to think or look for it, because that's the difference sometimes between an adolescent and an adult, is the ability to think ahead and explore options, because they're feeling very impulsive in the moment and they have a less evolved prefrontal cortex that they're working with. So here are some actual skills that can help you in the moment when you're working with a suicidal feeling, an urge to self-harm, a really strong reaction to something that feels disproportionate. A lot of these are distress tolerance skills. So tip the temperature, you're actually activating your mammalian dive reflex, which is impacting your vagus nerve. It's a reset, and it will slow your heartbeat down for a little while, 10 minutes, maybe 20 minutes, depending on the situation. Another thing that we know is very helpful is intense exercise. So if something has changed in the routine with COVID, as in maybe they were doing sports and now they're not, it's very important to try to at least simulate some of that, if at all possible. We're also not moving around as much day to day. So if all classes are inside, in front of a computer all day, finding a way to simulate movement, like you would be changing classes or going in and out of school. Maybe not, always intense exercise, but at least getting some movement in. Distraction methods, we talked a little bit about already, but really finding healthier ways to distract. They do need to be intense at times. And finally, something that we really teach is mindfulness practices. There are several that directly slow the heart rate. So this isn't just about meditation. We're actually using things like breathing techniques, progressive relaxation, which is clenching muscles and releasing them, grounding and imagery, to try to actually, manipulate our autonomic nervous systems a little bit into slowing down so that we can cope better in the moment, and have a little bit more clarity. In DBT, we call that accessing wise mind, being able to balance our emotions and our logic at the same time. So our very last piece before I am finished, and would be happy to answer questions if you have any, is urge surfing. So really we're trying to find at first some non-judgmental acceptance of these urges. Like, yes, I'm having suicidal urges or self-harming urges. I can accept that as a truth, and you want to avoid denying them, not giving them proper attention when they come up. You definitely want to label them and practice some acceptance around the fact that it may happen again at some point. And that, you kind of have a plan, like you know what to do, instead of it being this thing that you just really hope never happens again. That's what reality acceptance can look like. So our goal is to not panic. I want to use this graphic really quick to talk about the importance of surfing urges. So at some point when you're a young person or somebody you may know is surfing an urge, they got to this peak part where the red arrow is, and they tried a certain behavior like self-harming, And it worked to decrease the wave of the emotion as it was going, kind of at this crest, this really difficult top part. And it might be that over time, as that wave comes up again, you are tempted to cope with in a maladaptive way, essentially, earlier and earlier. So with the orange arrow, you're coping with, a kind of a medium amount of distress. At the yellow arrow, you might be maladaptively coping by self-harming with, kind of a minimal level of distress. And then at the green arrow, you might start coping just at the very beginning of a negative emotion or feeling or thought, because you really have closed your window of tolerance to be able to surf that urge and ride that wave through. So being able to practice sitting with urges, not panicking, floating, distracting, using emotional regulation skills and mindfulness skills, you can see how that's very important to get ahead of these maladaptive coping mechanisms such as suicidal ideation and self-harm, addiction. This is huge in addiction, looking at this arch and realizing when they started using a substance to help bring that feeling down and when they started using it constantly so that they could avoid feeling the feeling. So that is my talk, some basic DBT skills to get you started thinking about what you can do to work with this in the moment and to plan ahead for it.
Thanks, Melissa. Would you please go back to the first slide on safety planning? One of our attendees was hoping to look at that again.
Sure. Yeah, these are the kind of more gray area parts that you want to assess of the safety plan.
And all of this webinar will be posted on our website and our YouTube. So if you'd like to go back to these presentations at any point, you'll be able to do so. Also, feel free to screenshot if that's easier for you. Elizabeth, did you have anything else that you wanted to add before we start Q&A?
No, I think it's great if we want to go into Q&A. Thank you, Melissa. That was great.
All right, so one of the questions we have is, where's the resource for creating a safety plan? And then if anyone has questions, please feel free to just drop them in the chat.
So I'm actually grabbing the book that I got that particular safety plan out of. It's right here on my desk. I can show the book. Oh, that's backwards. Let me see if I can flip my screen. Hold on. That's not what I wanted to do. I'll actually write it out in the chat box. So this is a DBT book and it has a safety plan in it. If you were to Google safety plan, DBT, you would, okay, got it. You would be able to access some safety plans that exist already as well. So there we go.
I'm going to make a copy and put another one in the chat box to a link for one online. So you guys will have that too. If I can get it to, how do I paste? I think it pasted there.
And I just wanted to mention, I'm going to drop into the chat while Elizabeth is looking for that, the link to our contact page of our website. So if anyone has any questions after the fact and would like to contact us, feel free to reach out via that page. You can also reach us at our phone number, which I'm also going to drop into the chat, and we can answer any of your questions about our services or anything else that you might be wondering about. And it looks like we have, how do you feel about working with suicidal teens over the internet?
I don't think it's ideal for sure, but at this time, I feel like, we have to do what we have to do. And right now, all of our services are online and through telehealth, and so we've been offering our DBT groups that way. I would say that something that I don't know if we mentioned, but that I wanted to speak to is the importance of including parents in the treatment when you have a child or a teenager that's suicidal, or even honestly a young adult. And there are some clinicians who might be more wary about doing that because they want to protect the privacy and the confidentiality of the relationship with that client. But in my experience, sometimes the biggest factor that has made a difference in preventing a teenager from acting on the suicidal behavior is me having a relationship with the parent where I can pull the parent in, I can talk with them about what's happening, and we can strategize together to come up with what's the best plan for this young person. And I feel like that for me has been just a must have. I must have a relationship with the parent. And I do feel like that helps a little bit with the internet, that if I can meet with the parents every other week or once a month to get, because they have their eyes on the teen, they can be helping me to know more about what's going on if I'm just working with someone over the screen. But I can still safety plan, I can still assess for suicide over the screen as well as I can in the room with someone. And I haven't actually, in my own experience so far with teletherapy, I haven't found there to be a reduction of lack of connection. I've actually found that the emotion seems to get transmitted really strongly through the screen. And so I feel like I have a good feel for how someone is doing through the contact that we have. So, Melissa, would you say anything else about working with teens who are suicidal over the internet?
I've noticed some interesting things about wanting to be seen through the video, so I've been playing with that a little bit. I've found that I like to see the teens, especially when we're in group together, but sometimes phone calls can be effective as well. So if there's something about sitting in front of the computer after they've been doing it all day that's becoming a barrier, I'm finding that talking on the phone and maybe sitting outside together talking on the phone in a private space, of course. But quarantine has just, or staying at home more often has changed things a little bit with the video. And so kind of opening up to the idea of talk being effective.
Awesome.
Any questions or concerns or thoughts that people are having?
Well, and I also just wanted to mention briefly that since we're speaking about so much about DBT skills, we have another training upcoming that's generally for clinicians, but it is about DBT skills. It's led by Dr. Olson on October 9th, and you can register and learn more about that on our website in case you want to learn a little bit more about DBT.
Well, thank you all very much for participating today. I hope it's been helpful. And if you ever have questions or concerns, please don't hesitate to reach out to me. I'm happy to try to be a resource or a support or connected in some way if there's something that we can offer either at the collective or that I could try to be helpful with. Thank you for your time today.
Thank you.